Welcome everyone to our first BJJ podcast of 2025. I am Andrew Duckworth, and a warm welcome back to you all from your team here at the Bone and Joint Journal. I'd just like to start by thanking you all for your continued comments and support for our series, as well as a big gratitude to our many authors and colleagues who take part. That highlights just some of the great work published by our authors each month. So today for our podcast, I have the pleasure of being joined by two authors from a paper published in the January edition of the BJJ entitled Robotic Arm-Assisted Medial Compartment Knee Arthroplasty is a Cost-Effective Intervention at 10-Year Follow-Up, a cost-effectiveness analysis from a randomized controlled trial. So firstly, I'm very pleased to be joined by Mr. Nick Clement, who is a fellow editorial board member here at the Journal and one of my awesome colleagues and friends here in Edinburgh. Nick, to have you with us.
Thanks very much, Andrew. It's nice to be here and such a lovely introduction. Brilliant. Love it.
I'm glad you approve. And secondly, Nick and I have the pleasure of being joined by one of our awesome colleagues from the West, Mr. Mark Blyth from the GRI. Mark, it's great to have you with us.
Hey, delighted to be here. Thanks.
So guys, maybe Mark, I'll start with yourself. I thought, I was hoping you maybe give us a brief overview of your experience with robotic knee replacement over the past, decade or so, and maybe some background with that of the original study that this work is based upon.
So, Andrew, we got first involved with the Mako robotic system around 14 years ago, and we're lucky enough to get the first system to be used outside of the US. It was originally designed to be used for just unicompartmental knee replacement, and it was of interest to us certainly because I felt there was this technique gap, because unicompartmental knee replacement, even in experienced hands, can be problematic. And so we were very excited with the technology, and of course, therefore wanted with this new technology to try and compare against the standard of care, which was using traditional instrumentation and was the Oxford mobile bearing implants.
Yeah, no, absolutely, Mike, and I think that's insight of what, like you say, the standard of care was at that time. And Nick, if I maybe come to yourself, we all know Mark and you have published a huge amount of literature in this area, some of which obviously you've published in the BJJ as well. Can you maybe give us a take on the state of the current evidence for robotic knee replacement as we stand at the moment?
I think there's more and more papers every day kind of coming out with robotic, this, that, and the other. I think there's more systematic reviews and meta-analysis than there is evidence at the minute. But it's kind of, you got to be really careful what you look at and what you read, because obviously there's loads of different robotic systems out there and likely with different results. So I think it's really difficult to get a real grasp on the evidence, because there's something new every day, more or less, with a new spin on things. But certainly you said knee, but this is really about unicompartmental knees as opposed to just total knees. So certainly from the uni side of things, we published a review in the journal a few years ago. Yeah, time flies. About 2022, I think it was, and that showed basically that the robot was more accurate. Funnily enough, it's kind of what it's designed for. But at that point in time, there was no difference in the functional outcomes. I think there was slightly less complications overall in the robotic lot. But that's using proms that were designed for a total knee replacement, kind of. And Mark's previous papers have really expanded on how probably the outcome measures that we use are a bit useless to try and pick up the small difference that we're trying to detect. But certainly from registry data more recently, the survivorship is better with a robotic knee, and that's probably not arguable anymore now. Certainly at least a couple of % better.
Yeah, absolutely. I think you sort of touched upon it in related to that review, and I remember we did a podcast on that as well. And so maybe as a brief introduction to this paper now, you've obviously looked at the cost, so what made you look at cost effectiveness in the way you have done in this paper? And you talk about it in the introduction quite nicely.
I think kind of that's the next big thing, isn't it? Cost, like this robots. So when it first came, it was £1 million. Why on earth they ever put it in Glasgow? You think somebody would have, anyway. Nonetheless, it's come down in price, got a little bit better, but certainly within a healthcare system that we have, healthcare system we have in the UK, we've got to justify the cost. And I think that's kind of been the big driver of, certainly for me, is to try and justify this new technology. Mark's the same, really. He's kind of spurred me on. So we published a Markov model back in 2019-ish as the first one I ever did. It was good to do on some early outcome data, Andy Pearl's data from HSS on survivorship, and using the then known outcomes, EQ5Ds, and kind of pieced it all together. But that was all, I'm not going to say made up. That's what a Markov model is, best guess, isn't it? Where the exciting thing with Mark's data, it's real. It's absolutely solid. And he approached me at the Scott meeting a couple of years ago, maybe it's 2022. We then wrote the 5-year data up because Mark was wanting to do a Markov model with that data, but with no need to, because it's real data. You don't have to make stuff up. And then that led on to this 10-year paper, which is obviously, I'm not going to spoil the thunder of what we're going to discuss, but kind of this is real data with real follow-up and probably real costs.
Yeah, absolutely. Yeah, sort of takes us on quite nicely to sort of the meat of the paper and how you sort of did it. So, just to sort of clarify for the readers, the aim was to perform an incremental cost utility analysis and assess the impact of differential costs and case volume on the cost effectiveness of the robotic arm-assisted medial unicompartment on the arthroplasty and how that compares to manual. So, Mark, if I maybe come back to yourself, going back to the original paper, can you just give us a very brief overview of the sort of inclusion-exclusion criteria, who was in the study, and particularly what the two interventions were for the groups?
Yeah, so to put it simply, the inclusion criteria were patients who were suitable for a unicompartmental knee replacement for medial osteoarthritis of the knee. And so they have to have intact ligaments, they have to have disease that is limited to those joints in the main, that part of the joint in the main. And so in our practice at that time, we were quite enthusiastic unicompartmental knee surgeons. So it was around 20% of our practice. It's around 30% now. But it was pretty much standard mental patients. And they also had to be able to comply with the study protocol, of course, for the study. And also they had to have isolated unilateral disease. So they couldn't have significant pain in the other knee that might affect the PROM scores operatively. And so we were able to recruit over a 2-year period to the study. The study was designed to look at accuracy of surgery. So how good the surgery was performed at delivering the preoperative surgical plan. And we were able to demonstrate that the robotic system was much more accurate at delivering the implant position in all 6 planes, or all 3 planes. It's much more accurate at delivering the preoperative plan. We looked at PROMs, and Nick's alluded to the early outcomes, and we were unable to demonstrate any difference. One of the difficulties you've got with unicompartmental knee outcomes is that they are universally very good. And you alluded to that with the PROMs that we've got. There's a massive ceiling effect, and really very difficult with those PROMs to demonstrate any difference in outcome between 2 types of interventions, because they're based really on, like the Oxford score is based on activities of daily living rather than more discriminatory activities. And so we weren't, even with the Oxford score, we weren't able to demonstrate any difficulties.
Absolutely. In terms of the sort of planned follow-up for the study, Mark, how did that sort of pan out? What were the sort of time periods that you were looking at them after the intervention?
So compliance with follow-up has been good. We've had some deaths, and around 7% in each arm of the study at 10 years, which is probably pretty standard for this patient population. We have had some loss to follow-ups where we've not managed to interview and to examine patients at longer follow-ups. But overall, we've managed to see around 80% of our patients. We have that great advantage in Scotland, of course, with our national PACS, National Archive system, where we can search on PACS to look for any revision procedures that might have been performed. So we're pretty confident that we've captured all of the patients at 10 years if they've had a revision in the NHS. It doesn't exclude, that does of course exclude patients that might have had it done in the private sector, but we have very low rates of private insurance in Scotland. And of course, it doesn't include anyone that might have had a revision elsewhere, for instance, in England.
No, absolutely, Matt. That makes total sense. And Nick, if I could maybe come to you before we sort of move on to the results of the study, and can you clarify for our readers, as basically as you can, the calculation of the QALYs and how and the costs and how that was done?
So QALYs aren't really very hard. EQ5Ds are used to assess quality of life gain or health rate of quality of life. So if you go from 0.6 to 0.9 post-op, 0.6 to 0.7 post-operatively, you've gained 0.1 of a EQ5D. If you keep that for 10 years, that's 0.1 times 10, that's 1. So you've gained 1 QALY, quality adjusted life year. So it's pretty simple. And then you just divide that by the cost. So if all the cost, is divided by the QALYs gained. So if somebody costs £1,000 and you gain 1 QALY, it's £1,000 QALY. And then you've got a cost per QALY up. That NICE suggests kind of ranges on something like £20,000 cost per QALY is what's really talked about. But that was based on data from 20 years ago, even longer than 20 years ago now. And that was what it cost, or what the estimated cost was for dialysis, I believe. And they thought that was a good intervention, and it cost about £20,000 per collie. And they thought that was a good number, but that was 20 years ago. And so I don't know what that, but it's never really changed, to be fair.
No, absolutely. And in terms of that you had sort of 3 costing models that you used, you just sort of briefly describe those and any sort of assumptions you also made as part of the analysis.
Those 3 cost models were really down to Mark, because he really tried to hammer the data the best he could to try and make it believable. Because really the real cost analysis that we should do includes everything. It also includes the 2 infections. And that definitely makes it the dominant procedure. The dominant procedure is basically something that costs less and delivers more, which is impossible in orthopedics, I think. But anyway, there might be something out there, but that's kind of the aim, whether we ever get there or not. And Mark didn't believe that. He thought, well, probably not. He's right. So we excluded the infections as just a random event. There was one early one, Mark, was immediately post-op, a wound one that may or may not actually been infected, but was managed as infection just because there was a wound problem. And the later one, I think, a hematogenous, about 4 or 5 years, can't remember. But so we took them out, and then that left, I think, 5 revisions. But it was all reoperations excluding infection. That was the next model. And Mark still didn't like that. Even though it's real, that's what we should have presented. So went for a 3rd model. There's actually a 4th model, to be fair, that Mark even didn't make it into the paper because it was getting confusing. Then we went for a 3rd model that actually excluded the arthroscopies, because Mark thought there might be a bias in patients that they're going to make or send them away, as opposed to you go to Oxford, actually you might get an arthroscopy. So we excluded those. I think it was 3, So that left for 5 revisions.
Yeah.
And that's what the 3rd model was. There was a 4th model based on, because of the 5 revisions, I think 2 of them or 3 of the 5 had loose base plate, 2 had loose, and we tried to base the cost effectiveness around that. And it was still less than 20,000, but it didn't make it into the paper.
Absolutely. So you've sort of alluded to that already, Nick. If we move on to those results, in terms of the revision rates, you sort of described it, but there were sort of 5 patients in the manual group revised to TKA, 3 had an arthroplasty, and 2 had a DARE. You've described there were no re-interventions in the robotic group. Is that correct?
That's right. And probably the other thing to emphasize is that the 5 revisions in the Oxford group or the manual group is actually less than the average NGR revision risk at 10 years. So that works out as something like 7% revision risk.
Yeah.
5 divided by 65, I think, in that group, the revision risk is around about something 7%. So that's lower than you'd expect than the 10%. So it's still quite low. So even though it sounds a lot, it's actually what you'd expect from a mobile bear. Absolutely.
And just before we move on to sort of the implications of it, what did you actually find, sort of briefly in terms of the costs when you did all your analysis?
That's a massively open-ended question. It was more cost-effective, Mr. Duckworth. I think it's really we could be here all day about how much things cost and how much the robot should be, how much the implant should be with the robot, whether you should reduce the cost of the implant. But
could I butt in here, because I think the cost effectiveness depends on what you put into the model. So in our study, it was, to put it simply, around £1,000 additional per case. And around £500 of that was the cost of the robot, around £250 for the CT scan, about £250 for the disposable. But of course, those are just costs that were correct at the time that we did the study. But those costs are variable because it depends how many procedures that you do per year in your unit. Then the unit cost per case for the robot goes down. It depends what a CT scan, whether you report it or you don't report it, and what the disposable costs that you've negotiated with the manufacturer are. So all of those are variable, which is why it's difficult to be certain. But if we say it's £1,000 per case, if you then say that the average cost of a revision is around £20,000 per case, then you do the maths to work out how many cases that you have to do to make it cost effective. And so you have to have a revision rate that at 10 years is around 5% different to make it cost effective. And Nick's right. I think I did struggle with the concept of including the infections. This was a relatively small study. These were random events. They're massively expensive to treat, and they really do skew the data. So I was much more comfortable to exclude those. But even if by excluding those, you still find at 10 years that robotic unicompartmental knee surgery is cost effective.
Yeah, absolutely. And if we sort of move on to the implications, Mark, what do you feel from this study alone are the key take-home messages? I suppose with any, limitations of the study and the data itself.
Well, I mean, I think the first and obvious limitation is that it's a relatively small study. It was powered to look at the accuracy of surgery rather than any particular cost effectiveness analysis. So there is a concern that in a wider study with more surgeons in a multi-center setting that we wouldn't find the same results. But I think it's pretty encouraging that for some relatively modest upfront costs, but it's because of course those costs over time will come down as it does with all technologies. There are cost savings potentially to be made. The complication revision rates in that systematic review that you alluded to earlier have been shown to be less with robotic unicompartmental knee surgery. And so I think that the benefits are there. And I think it's just a matter of time before we prove it in other wider and larger studies.
Yeah, absolutely, Mark. And Nick, if I come back to you in terms of the actual findings of your paper, in terms of you've moved it already, but in terms of survival, how does that sort of fit with the other literature and the registry data?
Well, yeah, I kind of certainly early data from Andy Pearl's group, very large group cohorts, 400 patients, showed very low revision risks early on, up to 5 years. But the more recent paper we published, or they published as a group, for 10 years, it did show the revision risk did increase. Not quite but it was getting up to 8 to 9%. I think it wasn't quite the 10%. So it did increase, but certainly early revision risk was less. But when you look at the Australian registry, I just looked at it last week for presentation as it happens, and certainly they've got data out to 6 and 7 years now, and there's a definite difference of 2% there and thereabouts at that time point, which is significant. And kind of, what would you have if you had to put, so basically the numbers to treat there is 50, isn't it? So if every 50 knees that you're going to do, you're going to save one revision. Sure, that's not that that's a good thing, isn't it?
Yeah. And in terms of, because I thought what was interesting was in your sort of penultimate paragraph when you talk about, if you extrapolate it in terms of how you make it cost effective or it's cost neutral, those figures are quite interesting, in terms of, it's not what I almost expected. I expected it would have to be bigger than that. But like you say, reducing the cost of the implants used for robotics by £141 or more would make it cost effective in a unit undertaking 400 a year. That's quite amazing.
Yeah, and it is kind of mind-boggling. Even in units that you're sitting in currently,
yeah,
the manual partial knee replacement costs us around about £800 more than the robotic knee replacement does. So actually it's probably cheaper to buy a robot and pay for the consumable part, which does vary in price depending on how much discount you get. But this price is £1,000, but there's always a massive discount. So that probably it'll probably be cost neutral, but it'll be definitely cost effective because actually we're paying so much more for the manual implant that we don't normally have on the shelf.
Absolutely. Yeah, that's very interesting. And Mark, maybe if I finish with yourself, I asked this question to both of you, I think actually in our podcast 2 or 3 years ago about, does this now prove that robotic uni is a cost-effective intervention? But from what you guys have said, where do we go next? What more data do we now need, or do we need any more data to prove that?
That's a great question. I think this simply adds to the literature. The problem will be that when you look at 10-year outcomes and revision rates, that already that the model that and the funding model that you've got will be different. And Nick's alluded to this, in terms of this, the number of cases that you do and the cost that you pay for your implants. And so if we look at our general surgical colleagues, they've used robotics to change the pathways that patients go through so that all of the care is centralized with units that do robotic malignant prostates, for instance, or low anterior resections. And so you can imagine a world in the future in orthopedics where you have national treatment centers opening up, doing high volumes of arthroplasty, where the additional costs of having a robot become really very low indeed. And you have much more control over your surgery, and hopefully with that reduced revision rates, which we will see across the board, that it will absolutely be cost effective in time.
A good take-home message for the future and where hopefully things will be heading. Well, both, I'm afraid that's all we have time for. So thank you so much for taking the time to join me, and congratulations on a great study, another great bit of work from you both, and which has clearly added a lot to the more to the literature in the area. It's great to have you both with us. And to our listeners, we do hope you've enjoyed joining us, and we encourage you to share your thoughts and comments through our social media platforms alike regarding our podcast today and the paper itself. And we hope, thank you again for joining us. Take care, everyone.